afternoon to all. I welcome you to this prestigious session. We are now going to have, I expect, nice presentations dealing with different issues which are very much interesting to all of us as surgeon. May I call first speaker, Dr. Bahadir Joglo. I first welcome here to Egypt, his home, because he's used here to come every now and then. His talk is going to be about the role of intraoperative pathologic assessment during breast surgery. I think we're going to keep the discussion at the end of the session, and hope that each speaker sticks to his time.
Okay, good afternoon. Thank you very much for the kind introduction. Today I have two talks, one now and then I will have another one. And yesterday we had a very good debate with the radiologist. Dr. Kamal is here. So we will continue to debate here. So it's a good continuation. And I would like to congratulate the organizers putting ourselves in order, back to back. So today, another topic, which is not maybe related to surgery. Here now we're talking about intraoperative pathological assessment, where we will discuss about whether this is a crucial thing in your daily practice. Now you see four beautiful ladies here. These are pathologists working with the Senatric, and probably most of you know about the Senology Academy. And these, only three of them, of course, the breast pathologist, one of them is a GI pathologist. As you can see on the left-hand side is my wife, beautiful wife. So she is a pathologist. So my talk now is approved by a senior pathologist. So why do we do frozen section or intraoperative assessment? So our aim is to do R0 excision, whether in breast or in the axilla, because we want to prevent reoperations in our patients. So what about the role of pathologists here? Because we're working together. So they confirm the diagnosis, which means that if you're looking for the margin, they say this is negative, or sometimes the distance between the clear margin and the tumor. And secondly, they're looking for example, you're asking for the sentinel node biopsy, and they are saying whether it's involved or not. But they are doing in two places. One is intraoperative, if you ask from them, which is temporary. Don't forget about this, because the false negativity is always there. So you shouldn't blame them that when they say sentinel node is negative, then it turns out to be positive after 10 days. Or the margins may be questionable during the operation, but you should depend on the permanent report. So this is the most weak point that you should not depend during the operation. So what we do is to do the tissue diagnosis confirmation, which I will only underline very shortly, surgical margin assessment and sentinel lymph node assessment. So for the tissue diagnosis, we don't recommend you to send whatever you find in the breast and send it to the pathologist, whether this is tumor or not, because especially if the lesion is less than 1 centimeter. I don't know if there is any pathologist here in the audience. If there is, yes, there is one. Because if the lesion is less than 1 centimeter, we had this problem all the way back in the history, because they are using and they're freezing this tissue altogether, so there won't be any tissue left for the permanent assessment. So it is crucial not to send everything to the pathologist. If it is possible, please send it with an excision or with a core biopsy, of course. Not excision anymore is recommended, but here, especially for the biopsies 4 or 5 lesions, please send the pathologist a core biopsy. What about the B3 lesions? I will not talk about this much because Yazan will be talking about this, but in these cases, like ADH or LCIS, we recommend you to the excisional biopsy, because you're confirming, you're having this diagnosis by core biopsy, and with this, you should send it to the pathologist by excising the lesion. So the secondary lesions is those lesions that during the surgery you find it coincidentally, and you can send it whether this is a secondary tumor or not. That could be understandable. So the surgical margin is the frozen section assessment is necessary. Most units do not perform, but leave it to the permanent assessment, especially in the United States because of the cost, but the reoperation rate is from 15% to 40%. Well, you can do cavity shaving. It is not that difficult. And here they reported that the reoperation rate is less than 10%. What is cavity shaving? Is it really a difficult thing? Because with the cavity shaving, you're not sending the pathologist all the shavings to look at it because it takes too much time and cost. So you do it and send it for the permanent pathology. So at the end of these, all studies, the meta-analysis show that 60% less likely that you have positive margin after cavity margin, and also again 60%, around 60% less likely to do the reoperation. One study from Turkey, from Istanbul University, they compare the frozen section and cavity shaving, not only cavity shaving and not cavity shaving, and they didn't find any difference between frozen section and cavity shaving when regarding the reoperation rate in these patients. Should we do a microscopic assessment or a microscopic assessment? Well, I do personally microscopic assessment with my pathologist, like we did the argument with the radiologist. I never look at the MRIs or the mammography by myself. Always we sit together with the radiologist. So here again, we sit down with the pathologist during the operation. I mean, we look at it at the microscopic. If it is far enough, from the surgical margin, we do not ask for the microscopic assessment. So what is the impact of this? Because reoperation is also costly, and also it can cause bad cosmetic outcomes. So it is crucial to prevent reoperation in these patients. That is why frozen section or cavity shaving should be considered in these patients. What about the cosmetic outcome other than reoperations? The frozen section, well, you do a small resection. Maybe cavity shaving, you may have some question in your mind. Maybe it's a larger resection. No. The studies so far in the meta-analysis said that they have similar outcome. And the cost efficacy, they are both having the same, in the beginning, because if you're doing a frozen section, you may prevent some reoperations, as I showed you. So the study from India, as you can see here, they show the definitive cost efficiency from the frozen section part, because you prevent some unnecessary extra operations, although the frozen section has an extra cost for each patient. But they prevent nearly 50 patients out of 800 patients. So this means that they reduce the cost of the reoperation in contrast to the cost from the frozen from all patients. So again, the cavity shaving and no cavity shaving, they have the similar cost. This is the data from United States. So coming to the sentinel lymph node biopsy, this is also an issue that we should consider during the operation, because nowadays many people say that in the upfront surgery, because up to 2 nodes positivity, you do not do axillary dissection anymore, because previously we were asking the sentinel node if it is 1 positive, we were doing axillary dissection. But nowadays, because of the ACOSOC Z11 and AMAROS trial and SYNODOR 1, all those trials show that up to 2 node positivity, you don't need to do an axillary dissection. So the question is it necessary during upfront surgery? Also, is it necessary after neoadjuvant chemotherapy? Because that's another setting that you should consider doing an intraoperative pathological assessment on the sentinel lymph node. So you know that if the sentinel node is negative, you do nothing. Up to 2 positivity, you may do observation. AMAROS says you may give radiotherapy, but it is a post-operative issue, so it doesn't require any pathological assessment during the surgery. But if the positive node is 3 or more, all the studies are recommending you to an axillary dissection. So the question is, if you retrieve 3 nodes, minimum 3 nodes, should you go to frozen section? Or another question, maybe it's not relevant for today, but you have 2 nodes, and it just may turn up to 2 positives out of 2. And we know that there are many series showing that when they do axillary dissection, 50% of the time you have extra non-sentinel nodes positivity. So would it matter for you? So it depends on your, of course, decision on your MDT. So this study from Thailand showed that if they do routine frozen section for everybody, so they found that in 13% of their patients that it was useful to do, but only 13% of them. And there's no false positivity for frozen section for upstaging. There were only 1 false positivity, but that was 1 out of 2 nodes, so it didn't differ anything because they didn't do axillary dissection. But only one patient, which is 3%, missed unnecessary axillary dissection due to understaging. So that was a false negative case. So they missed it, and because it was 3 positive, because they thought that it was 2, and they missed an axillary dissection. But this is only 3% in one patient. So this is just not a recommendation for you, just the numbers for you to consider. So also there's another issue. It may happen to everyone, and I'm sure that it happened to most of you. You thought that you retrieved 2 nodes, and they look at on 2 nodes in frozen section, but the permanent report comes there were 3 nodes, because as always, when they do the permanent pathology, they find some more nodes, some small nodes there. So it may have an impact. Maybe there would be 3 or 4 positivity, even in those small nodes may change your treatment in future. But the false negativity is very low, less than 5% in these cases. So, but, you know, there are some cases which makes us a little bit hesitated during our sentinel node biopsy procedure, especially in intraoperative assessment, and those are the lobular cancer patients, because there we know that we have more false negativities in our patients. The studies so far show that if the sensitivity of frozen section is especially low when you're dealing with elderly patients over 60 years of age, multifocal tumors, and the large tumors. So, and also, another part is if you retrieve only 1 node, that is dangerous for the lobular cancer, but I don't recommend you to find 2 or 3 nodes. If it's 1 sentinel node, it's 1 sentinel node. You don't have to retrieve 2 or 3 instead of only doing 1 if it's not marked by blue dye or radioactive material. But the number of retrieve nodes increases, then the sensitivity of frozen section is increasing here. And also false negativity on the other hand, if the tumor metastasis size is small, it's more likely to have a more false negativity and also invasive lobular cancer, as I said. So coming to the setting after the neoadjuvant treatment, here there is one recommendation. If it is negative, then you do nothing. But if it is positive, even micrometastatic disease, all the recommendations so far, although there is no evidence for this, we regard this as a true, because there's no study, and the studies are coming. So should we do frozen section for every node that we retrieve during the frozen section in patients who receive neoadjuvant chemotherapy? So as a conclusion, when just getting all these data together, I'm not a pathologist, but I'm working very close with the pathologists, and I really, you know, think about them when doing my surgery, when asking something about intraoperative assessment. So please, please do not ask any unnecessary, you know, assessments from your pathologist, because the frozen section or touch print, whatever they do, is not so reliable as the permanent pathologist. So for the margins, yes, of course, if you think that macroscopically it is near to the margin, you may ask intraoperative pathological assessment from your pathologist if you're not doing a cavity shaving. For the upfront surgery, if you retrieve 2 nodes maximum, there's no need to ask for a frozen section. If you will consider that 2 out of 2 is positive and you will not do axillary dissection, then why you're asking for a frozen section? Do not take the time of your pathologist. But if you retrieve 3 or more nodes, and if you think that it will change your practice, then you may ask a frozen section from these 3 or 4 nodes. I mean, but this is not a berry picking type. Really, it should be the sentinel nodes. So, but coming to the setting after the neoadjuvant chemotherapy, there is a must to send your sentinel nodes, even 1 node, to your pathologist for the intraoperative pathological assessment, either for a touch print or for the frozen section, then because it will change the practice, and your practice should be changed not to stay there and do the axillary dissection. And even more, the radiation oncologist will give irradiation to the parts of those regions, either to the level 3 or supraclavicular or internal mammary, according to their guidelines, institutional guidelines. So this is all I would like to just give you as an address. As you can see that I didn't show you too much evidence on this. This is more on practical basis, and it should depend on your, you know, internal agreement with your institutional agreement with your pathologist as well as your radiologist, because your radiologist report is also important here. Why? Because if they say this, for example, if the axilla is normal by ultrasound or by MRI or by mammography, so here, if then the pathology report is negative, you can depend on this. But for the frozen, of course, there should be one just situation that if you find something meaningful would change your practice during the operation and preventing an extra surgery after you finish your surgery, then you may ask your interpretive histopathological assessment. Thank you very much.
Thank you, Professor Badir, for your nice presentation. Next speaker will be Professor Rasha Kamal, the conference president. She's going to talk about a step out of the comfort zone of fibroadenoma.
When breast imaging, radiologists see on imaging, when a breast lesion is seen on imaging and it completely fulfills the criteria of fibroadenoma, breast imaging radiologists and clinicians usually place themselves in the comfort zone. And because change always begins with one step outside this comfort zone, it is my job to take you out of this comfort zone today and take our step out of the comfort zone of fibroadenomas. But before doing so, we have to know how fibroadenomas appear on imaging. On a mammogram, fibroadenomas are either single or multiple circumscribed masses. They are oval, rounded, or macrolobulated, and they appear iso, hypo, or hyperdense to the surrounding breast parenchyma. When fibroadenomas age, they develop the typical popcorn calcifications, but we always have to remember that any macrocalcification was one day a microcalcification. And this is our first warm-up alarming sign when we see microcalcifications within a fibroadenoma. On an ultrasound examination, a fibroadenoma is either rounded, oval, or irregular. The margins are either circumscribed, lobulated, or partially obscure. The echogenicity is either hypoechoic, hyperechoic, or shows cystic changes, and the calcifications, both the macro and the microcalcifications, can be identified in fibroadenomas. And our second alarm sign is when we see a fibroadenoma which appears irregular with obscured margins, cystic changes, or microcalcifications. On MRI, they also appear as rounded or oval circumscribed masses with variable T2 and stir signals. They might show no enhancement or homogeneous enhancement, and the hallmark in diagnosing fibroadenomas on MRI when we see these dark septations within an enhancing mass lesion in the breast. And now we've warmed up enough, and we will going to take our first step out of the comfort zone of fibroadenomas, and we will try to understand what do fibroadenomas have to do with breast carcinomas. Our first step is the inherent malignant potential of fibroadenomas. Fibroadenomas comprise both an epithelial and a stromal component, and they are classified either into a simple fibroadenomas, the juvenile fibroadenomas, the giant fibroadenomas, and the complex fibroadenomas. The epithelial component of a fibroadenoma may develop a DCIS or an invasive cancer with a reported incidence of 1 in 1,000. And this incidence is higher with complex fibroadenomas, and therefore we're going to take a stop and have a look on these complex fibroadenomas. These are 3 different cases of complex fibroadenomas, and we will see that what we see in the pathology is reflected on the imaging features of these fibroadenomas. Because in the pathology, we will find that they contain apocrine metaplasia, we will find cystic changes within these fibroadenomas. There is sclerosing adenosis, which is reflected as irregular outline. And there is hypervascularity, which explains why these fibroadenomas increase in size, and we might find microcalcifications within these fibroadenomas. And when we have a pathology stating that this is a complex fibroadenoma, it is highly advisable that it should be surgically removed. Naturally, the fibroadenomas might remain stable in size, they might decrease in size, and they might increase in size. And this increase in size might be either physiologic in teenage, pregnancy, and lactation, but it might be also pathologic due to malignant transformation, or it wasn't a fibroadenoma from the start, it was either a phyllodes tumor or a misdiagnosed case. And the alarming signs that we see in a fibroadenoma is the increase in size, irregular outline, cystic changes, increased vascularity, and calcifications in young individuals. Our first case is a 57-year-old female. She came for screening mammography. This is her mammogram in 2017, 18, 2020, and as we see, there is a newly developed lesion in the right breast seen in 2020. This was her contrast mammogram, and the lesion showed homogeneous enhancement with dark internal septations, which is very characteristic for fibroadenomas. We revised her previous ultrasound examination. We found that the lesion was present in 2017, 2018, but in 2020 it increased in size and there is an increased vascularity within the mass. It was biopsied, and this was a fibroadenoma with DCIS. So the diagnosis in this case is a fibroadenoma with foci of DCIS. The teaching points: avoid dissatisfaction of search, compare always with the previous studies. Any change in density, morphology, or an increase in size more than 25% in 6 months, we should biopsy this fibroadenoma. The second case, a 29-year-old female with a palpable mass in the right breast that showed recent increase in size. She had an oval circumscribed mass lesion in the breast. Because she was young, we started with the ultrasound examination. There was moderate vascularity, and she had non-specific axillary nodes. Her initial diagnosis was a fibroadenoma, and she was assigned a BI-RADS 3, which means that she has to come for a follow-up after 6 months. Being viewed by a more senior staff member, he said, no, I will upgrade this mass lesion. I will give it a BI-RADS 4 because on the ultrasound he noticed that there are microcalcifications. A mammogram was requested, and here was the mass lesion with the microcalcifications. A biopsy was taken, and again this was a fibroadenoma with DCIS. The teaching point here is microcalcifications are not accepted in fibroadenomas in young individuals. We should never deter the diagnosis of malignant breast lesions based on the patient's age, and when a pathology report states that this is a complex fibroadenoma, it should be surgically removed. The third case is a 47-year-old female. She came for annual screening mammography. On her screening mammogram, there were 2 masses, one which was present in the right breast, and the other one is deeply seated in the left breast. According to the report written, the one in the right breast showed complex features, and close follow-up was recommended after 6 months. This is how it looked at the initial examination, and after 6 months, this is how it looked. And it showed increase in size and change in morphology. A biopsy was taken, and again, it was a complex fibroadenoma, and surgical excision was advised, and it turned out to be just a complex fibroadenoma without any malignant transformation. This was in 2019. She came after that for follow-up in 2020, 2021, and actually the lesion on the left side, it showed increase in size. Gradual, subtle increase in size. We compared the ultrasound examination in 2020 and 21, and there was increase in size and change in shape. A biopsy was taken, and this was a complex fibroadenoma with an invasive lobular carcinoma. We always have to compare with previous studies, and it is very important that we should refer to the initial study, not just the examination in the year before. Now we'll take our second step out of the comfort zone, and this step is the concomitant carcinoma and fibroadenoma. The question is, do fibroadenomas increase the chance of developing breast cancer or no? Previously, it has been suggested that fibroadenomas might increase the likelihood of developing concomitant breast cancer. Yet recent studies have proved that fibroadenomas themselves do not pose any risk of breast cancer development. The presence and growth of fibroadenomas and some carcinomas are likely related to abundant estrogen and to abnormal hormone receptor mechanism. Our first case is a 71-year-old female. She had a palpable mass in the right breast. She had an involuted fibroadenoma in the left breast, and she had a right breast mass lesion which looked a little bit strange. On one side, this mass was circumscribed with macrocalcifications, and on the other side, it was a speculated mass lesions with microcalcifications. This was her contrast mammogram, and again, if you look at the lesion, on one side it was not enhancing, and on the other side, the speculated mass lesion showed enhancement. The biopsy was taken, and it was an invasive duct carcinoma invading an adjacent fibroadenoma. The second case is a 43-year-old female. She had chronic eczema of the right nipple, proved to be Paget's disease. This was her mammogram. On the mammogram, she had a heterogeneous dense breast. There were no microcalcifications, but there was a very subtle asymmetry in the right retroareolar region. This was the ultrasound examination, which revealed multiple fibroadenomas showing complex features. And I think by now you can recognize the cystic changes and the microcalcifications within the fibroadenoma. An MRI was requested, and these fibroadenomas showed typical enhancement, typical for the fibroadenomas with dark internal septations. But there was very subtle enhancing foci, taking a segmental distribution in the upper inner quadrant of the right breast. And she had differential enhancement of the right nipple. Mastectomy was performed, and it revealed Paget's disease of the nipple with complex adenomas, and in the same time she had high-grade DCIS in the upper inner quadrant. The teaching point in these cases, whenever we have Paget's disease, it is recommended that we perform an MRI examination because it shows lesions which we do not see on the mammogram. The third step is the fibroadenoma mimics. We have a long list of lesions which appear exactly like the fibroadenoma. And the problem with these lesions that unfortunately they may occasionally show benign morphology mimicking benign masses in all imaging modalities. And some of them may occur in young individuals, which further increases the problem in diagnosing these lesions. This was a 29-year-old female. She had mastalgia and a lumpy breast. She came in November 2019. She performed an ultrasound examination which revealed multiple very small fibroadenomas. One of these adenomas showed some complex features with cystic changes. She was asked to come for a biopsy and she didn't come. We called her to come for a short-term follow-up, but unfortunately this was during the corona pandemic and she didn't come before September 2020. Most of the lesions were stationary, but the mass which we suspected to be a fibroadenoma with complex features increased in size, and she developed multiple other lesions as well. An MRI was requested, and unfortunately a biopsy was taken. This was a triple negative breast cancer, grade 3. The teaching point is whenever we have adenomas with atypical features, at least we should do a short-term follow-up, if not a direct biopsy. Any increase in size or change in morphology, we should either biopsy or surgically excise. The second case is a 42-year-old female. She had a recently palpable right paraareolar mass lesion. This was her mammogram. She had a lesion which looked typically benign like the fibroadenoma, and this was her contrast mammography, which showed features typical for fibroadenoma as if there were dark internal septations. Biopsy was taken and it revealed that this was a mucinous carcinoma. The teaching point here is that we have to respect the patient's age. The patient was sure that this mass was not present before, and whenever we have a newly developed lesion, we should biopsy this lesion. The last case is a 55-year-old female. She had a right breast adenoma that has shown rapid recent increase in size. This was the preliminary examination, showed a lower inner quadrant mass, which looked exactly like the fibroadenoma. When she came for the follow-up, the lesion has remarkably increased in size. A biopsy was taken, and it revealed a cellular fibroadenoma. And this is the second case when we have a pathology stating a cellular fibroadenoma. It might turn out to be a phyllodes tumor on excision, and it is recommended that we excise this lesion. Here, the rapidly increasing in size or cellular fibroadenomas, we should biopsy or surgically remove. At the end of my lecture, I just want you to remember that the vast majority of adenomas are benign. and the incidence is only 1 in 1,000. And not all complex adenomas are malignant. The cases that I have presented are a minority in the respect to the number of adenomas that we encounter in our routine daily work. So what to do so as not to miss a malignant fibroadenoma? We always have to respect the patient's age, compare with previous studies, especially the initial study, avoid the happy eye syndrome, and do not exclude cancer in respect to the patient's age and biopsy atypical mass lesions. The alarming signs, if we have a clinical history of a recently palpable mass or that has shown recent increase in size, on the imaging, any increase in size, 25% in 6 months, any adenoma with cystic changes, microcalcifications, irregular outline, or increased vascularity. And if we have a pathology report stating that this is a complex or a cellular fibroadenoma, it is preferred that it should be surgically excised. And thank you.
Thank you, Dr. Rasha, for this very nice and illustrative talk.
يعني هروح ارجع
Any question from the floor? Okay. Any question from the floor?
Professor Rasha, thank you for your أنا هنا. Thank you for your clear lecture. But you started your lecture by saying that macrocalcification started as microcalcification. فبس just we need to يعني a bit some clarification because يعني when we meet microcalcification خلاص we know that it is a ductal carcinoma in situ or this is in our mind, but if it is macrocalcification, how can I let the patient go without taking care, or one I'm gonna upgrade up to an MRI or something like this? Just a clarification about this point, please.
هو the microcalcifications per se does not mean malignancy. We have two features that we characterize microcalcifications with. First, that it is a microcalcification and the distribution. If it takes any specific pattern, a grouped or segmental, or if it is within a fibroadenoma, in an elderly individual, I might think that it is going to develop to a macrocalcification. I can give her a chance of a short-term follow-up. Because mostly it will turn out to be, if it is malignant, it will turn out to be a DCIS within the fibroadenoma, and I think a short-term follow-up won't harm the lady. But if I see it in a young individual, I usually recommend for biopsy.
Thank you, Dr. Rasha, for the excellent presentation. I'd like us to ask you about, I have never seen a case of carcinoma in a fibroadenoma actually. And actually, when my patients, they come to me and it is the risk of malignancy, I usually reassure them. صوت واضح كده؟ صوت. يعني I have never seen or encountered a malignancy in a fibroadenoma. And I think you are very lucky because you are doing a lot of imaging for women everywhere. But usually the patient is coming and concerned with the fear that there is an increased risk of malignancy having a fibroadenoma. I usually reassure them and tell them there is no increased risk for them. You presented cases. I think we should consider in our minds the age of the patients, and you told us about the follow-up. You were lucky because you follow up the patient and you find changes in the fibroadenoma. I'm going to ask you if I'm going to encounter a young female with fibroadenoma, multiple fibroadenomas, for how long you are going to follow up her?
هو يعني the first part of your talk, I totally agree with you, Dr. Ahmed, because I didn't see any case of fibroadenomas working for 15 years in Qasr Al-Ain, in Cairo University Hospital. In Bahia, يعني in the last 2 or 3 years, we have, I say, maybe 25 cases, either with lobular carcinoma or mostly with the DCIS. For the second part of your question, whenever we see a case of fibroadenoma, we don't have the luxury here to biopsy all cases, definitely, especially if she has multiple fibroadenomas. I always tell them then when you write the report, you should write them in a list. Say at 1 o'clock there is a fibroadenoma measuring so and so. So if she comes back to me or if she goes to any other radiologist, he has the option that he can go step by step with every fibroadenoma to identify which has increased in size or changed in morphology. And he has to document this by images. At 1 o'clock there is a fibroadenoma measuring so and so. And if it has some atypical features, you should mention them in a list.
Okay.
We follow up fibroadenomas from 18 to 24 months. We cannot downgrade them to BI-RADS2 unless they remain stable for at least 18 to 24 months.
Okay. I usually follow up my patients for at least 1.5 years, as you say, or 2 years.
Yes,
And then I keep them. Okay.
Yes.
Dr. Bahdir, I think you have a question.
آخر سؤال بس.
Last question, yes, because we don't have time. Sorry, Ahmed, معلش. He asked first. المايك يا جماعة.
What I would like to emphasize is the transformation from a fibroadenoma to carcinoma is none, because the fibroadenoma tissue is not a ductal tissue. So it's a coincidental finding where the fibroadenoma there is a duct in it, then it may transform into a cancer. So that's the chance for everywhere. So there is no chance of transformation from fibroadenoma to cancer. That is a coincidental finding. And when you give a number like 1 out of 1,000, the denominator is always the same because you diagnose the cancer, but denominator is always not reliable because those only that you discover as a fibroadenoma. But there are many fibroadenomas that you don't discover. So this is not like 1 out of 1,000. It is the normal incidence.
It's not our incidence.
Yeah.
This is what is stated.
Yeah, that's what I'm telling you. So
yes,
don't rely on those numbers.
Yes, when we noticed the increase in number of fibroadenomas with invasive lobular and I searched in the literature, and they said that the epithelial component within the fibroadenoma can change.
Yes, okay,
Yes,
but that is the same wherever you find it, anywhere in the breast. So
Yes,
there's
yes.
no difference. So
Yes,
I have 2 cases, one lobular carcinoma inside and one invasive cancer in the fibroadenoma, but that was the case because there was duct in it and in the lobular part of this acini, and they turned into a malignancy. So that is not because the fibroadenoma was there.
Yes, the reason why I performed this lecture is that most of the cases that we discovered were discovered on follow-up. And you can never know if the if the patient will be a delayed in the diagnosis or no.
I totally
Yes,
agree with you.
yes.
The thing that I would like to give a message from your side to them,
Yes,
that
yes.
there's no transformation chance from
Yes.
the fibro because the origin are totally different.
Yes, thank you.
Thank you, Doctora. Thank you very much.
شكرا دكتورة رشا. Now it is pleasure to me to introduce one of the eminent figures in oncoplastic breast surgery in the world, Professor Dr. Yazan Masanat, and his talk in management of B3 lesions.
Many thanks for the lovely introduction. Many thanks for the invite. It's a pleasure to be here with you in Egypt today. So I'm not going to talk about anything technical today. I'm going to talk about B3 lesions. So I'm one of the surgeons in England now, and I run the iBreast book. This is the only disclosure for me, as some of the events are sponsored, but there's no conflict of interest regarding this talk. And I need to apologize. Allah يسامح اللي كان السبب. We already had our full on طعمية, so we're half asleep today. So we're going to talk about the management of B3 lesions. There's 2 things that we need to address. What to do when you have a B3 lesion in front of you, and the follow-up is a very important thing. And we're not talking about BI-RADS3 lesions, we're talking about B3 biopsy code lesions. BI-RADS3 lesions are all biopsied in the UK. In other parts of the world, they sometimes follow them up, but in the UK, everything is biopsied. So the B3 biopsy code, what does it cover? So in this talk, we'll talk about the different lesions. We'll just touch on them. Otherwise, we'll spend 2 days talking about them. We'll touch on the guidelines, but concentrate on the British guidelines, the UK guidelines. We'll talk about the role of surgery, and we'll look at future risk and follow-up. So why are they called B3 lesions? The term B3 is, if you look at the biopsy, B1 is normal, B2 is benign, B5 is malignant. The B3 is those lesions we think they're likely to be benign, but because of the heterogeneity, we need some more tissue. Your pathologist will need to see what is adjacent to them to know if there's invasive or non-invasive cancer or DCIS. And what's one of the most important factors to decide if you're highly likely to have invasive or non-invasive disease is the proliferation and the atypia. And the atypia is the key thing on that biopsy. It does make a big difference when you hear the word atypia by the pathologists. And why is it important? In the UK, we have a screening program. The number or the percentage of B3 biopsies is around 7%. Some years it's down to 3%. Some years it's up to 12%. But when you remember that we screen about 2.5 million or 2.2 million a year, 80,000 are recalled, half of those are biopsied, and 3,000 of the biopsies are B3, nearly 20,000 are malignancies. Out of 3,000 B3, we find that there is about 500 cancers out of those. So it's not a small problem when you started looking at the bigger picture. In the past, everything had surgery until this working group was formed by the Association of Breast Surgery, and they looked at B3 lesions. Before looking at that, people looked at what's the risk of having malignancy. And the key word in that biopsy is atypia. So those are different types of B3s. So radial scar without atypia, for example, the chances of having malignancy on excision is only in the region of 7-8%. Papillomas without atypia, when you excise it, the chances of having cancer is also about 7-8%. But papillomas with atypia, the chance of having DCIS or cancer with it is about 30%, about 1 in 3. It's not a small chance. It's even higher than ADH or AIEDP. So not all B3 lesions are the same. So why are we treating all of them the same? It has been always a surgical motto, when in doubt, take it out. And that was the usual scenario. And most countries, that's what they do. Imaging abnormality, you have a biopsy, it's a B3 lesion, either radial scar or it's a LCIS or whatever. And then you do a surgical excision, you take that out and you know what's happening. But remember, your operation is not treatment. Your operation is only diagnostic biopsy. So the big difference between the amount of tissue excises or not. And the question from the UK working group was, do we really need that surgery or not? And you start thinking about what are we doing in breast surgery. Many things that we're doing are not logical, because if you look at studies like the LAURA study, we're not operating on ladies that have diagnosed DCIS or doing the large volume excisions, or ladies that have small invasive cancers like grade 1 tumors. We're sending them to the radiologists to have large volume excisions in a small study, or using the ice for freezing them, like cryoablation, while for a patient that does not have a cancer diagnosis, we're taking them to have an operation for the B3 lesions. And that's why this working group started. They published their first paper in 2018, and those are NHS screening guidelines. The aim is to do less surgery if we can. So how can you do less surgery? By improving your preoperative diagnosis. You need to reduce the surgical biopsies. And this is by doing larger volume excisions. So with the new guidelines, nearly 2/3 of the B3 lesions that were operated on in the past, we're not operating on them anymore. They're just doing large volume excisions for them. And if you look at the cost analysis, but that's on a UK-based work, it does save money. It's better for the patient. You're not putting them under GA. It's a smaller area you're excising from the breast with the large volume excision. It's cost effective. And for us surgeons, we're not taking patients to theater just to take things to know what they are. We're just only operating on cancers. And after that guidelines, there's some other guidelines. There's the International Consensus Guidelines, there's the Breast Screening Guidelines and Diagnosis, and there's the American Society of Breast Surgeon Guidelines, and there's the AGO Guidelines. So there's lots of different guidelines by different bodies, and they're not all the same. If you're doing an excision, diagnostic excision in the UK, more than 90% of your specimens should be less than 20 grams. And if your specimens are more than 20 grams, you're asked. And if your percentage is much higher than the 90%, you'll be stopped doing those operations. And if a specimen is more than 40 grams, it needs to be justified in MDT. Why did you have more than 40 grams in that excision? And that's all monitored externally. A couple of definitions before we go. Vacuum assisted biopsy is just a biopsy. Instead of you doing a true cut small core, you do a bigger core. Diagnostic vacuum excision is repeated vacuum-assisted biopsies to excise the area, which is usually up to 15 millimeters. Some people will do bigger excisions, and you're aiming for a 4-gram tissue. Therapeutic excision is completely different. It's for people that have cancer, like the small study, which is not addressed here. So, if you look at the vacuum guide of the UK guidelines, most patients that have B3 lesions, we do vacuum-assisted excisions for them, except for papillomas with atypia, spindle cell lesions, fibroepithelial lesions, mainly if you're suspecting phylloides. And that's not because the radiologists cannot take them out. They can take them out. It's because the pathologists cannot upgrade. If you have a papillary lesion, even with a large volume excision, if you don't get the whole papilloma, then they cannot rule out DCIS in them. So if you go back to that guidelines, let's look at some of the pathologies. The atypical intraepithelial ductal proliferation, or what is used to be called ADH on excision. If it's less than 2 millimeters, it's ADH. If it's more than 2 millimeters, it's, or the extent is in more than 2 spaces, it's DCIS. And that's why we need to have a larger sampling of that to rule out DCIS. And some people will go to the extent that one pathologist's ADH is another pathologist's low-grade DCIS. Sometimes there's lots of controversy there. So in the UK guidelines, if the biopsy shows ADH, then we go and do vacuum-assisted excision of the area with this sampling up to 4 grams or more. If there is no more atypia, or if the atypia is only ADH, then we do high-screen mammograms, yearly mammograms. But of course, if there is atypia, if there is DCIS or malignancy, then you treat that. That's the UK guidelines. But if you look at the NCCN guidelines, they still do surgical excisions. If you do look at the American Society guidelines, they still do surgical excisions. The Germans will do still surgical excisions. And it's mainly the UK that is doing less and less surgery. But the follow-up, if you have large volume excision, you're less likely to be missing something sinister. We'll just whiz through the different guidelines also. For example, lobular neoplasia. Also, if you have it on the core biopsy or on the vacuum excision of the vacuum biopsy, then we do a vacuum excision. If there is nothing more, they go on high-risk surveillance. If you find malignancy, then you treat the malignancy. Remember, pleomorphic LCIS is not classical LCIS. Flat epithelial atypia is not different, it's the same, and you go for annual mammogram. But when you have lesions that do not have lots of atypia, like radial scar without atypia, papillary lesion without atypia, or you can see like lesion without atypia, when you do the large volume excision, then they're discharged back to the screening. They do the mammograms every 3 years' time. So we're happy that the region is excised if we don't find anything more. Now, papillary lesion with atypia, that's different. We always excise them because the pathologists cannot upgrade them if we don't do that. Other B3 lesions like spindle cell lesions, cellular fibroepithelial lesions like cellular fibroadenomas, like phylloides tumors and adenoma-epitheliomas, we always also excise them. Now we excise the lesion. We found it's not malignant. We found it's only ADH, for example. What to do next? And that's the important question. Now, not all those lesions have similar high risk, future risk for malignancy. If they have non-proliferative changes, they increase their risk by 3% only. But if they have atypia, they increase the risk by about 17%. They reach the moderate risk category. But let's think for the minute. The high-risk surveillance that we do, or that's our guidelines, is only 5 years mammograms, or a mammogram for yearly for every 5 years. But I think it's the wrong strategy. The only reason I do it because it's guidelines, because the risk of having future malignancy, for example, from lobular intraepithelial neoplasia, is higher, closer to 10 years and above. So why are we doing only mammograms for 5 years? Not one size fits all. And remember that most of those patients, after the 5 years, they might have been discharged from our screening mammograms. So the literature does not cover that well. Certain pathologies look differently, and there's a very few studies. For example, this one from Ireland is 5 years necessary, and when they looked at that, they looked at retrospective study, 10-year data, and they looked at all the B3 lesions that we talk about. 600 patients, 110 of them had high-risk lesions, only 4, which is 3.7%, developed invasive disease, and 4 had recurrence, and half were diagnosed in the first 24 months, meaning that most likely it's not completely excised in the first go. That's why they were diagnosed in the first 24 months. And there's similar unpublished data from Newcastle, 10-year follow-up. Mainly the recurrences are in the first year, about 7% over 10 years, but that was not higher than the other benign biopsies. So in summary, not all B3 lesions are the same. When you're found on biopsy, what we do is do large volume excision. There's nothing wrong in taking them out surgically. That's still a correct strategy, but it's better for the patient just to have a large volume excision. It's less surgery, less scar, less likely of causing a disfigurement. And in some cases, you need surgical biopsies. Follow-up is something to think about. I follow the guidelines, but I think that they are wrong, in all honesty. So the wisdom is to know what you don't know. That's what Socrates. Many thanks for listening to the talk. I finished a couple of minutes early.
Thank you, Dr. Yazan. Next speaker, Dr. Ashraf Zayed, consultant of oncoplastic breast surgery at Royal Marcedine Hospital, UK, and at King Faisal Hospital, KSA. تفضل دكتور.
بسم الله الرحمن الرحيم. بسم الله والحمد لله والصلاة والسلام على رسول الله. Before I start my talk, I'll just add to Dr. Yazan that the difference between UK and Germany and America is that the waiting list time can fail a government. So we move to a mammotome to save the operation time because it is a government target. I thought I would add it. Now, my talk is a very straightforward and a very difficult, but it is a multidisciplinary issue. Is what happens? How can you manage a recurrence, specifically local recurrence? Recurrent breast cancer is always a concern for all of us whenever we plan treatment. Why do we have multidisciplinary meetings? Because we want to do the best to improve survival, but also to reduce local recurrence. So it does not only affect survival, it will cause a lot of psychological distress to the patient and also to the managing team whenever you get a recurrence. It's end of the world for many patients, even if it is curable later. Most of the recurrences happen in the first 2 years. It is a big party and then followed by another party after 5 years, because most of the recurrences will happen in the first 2 years, maybe also within 5 years. Recurrence is either a systemic recurrence, distant metastasis, a local recurrence, or a regional recurrence. The management will be, in a way, the guidelines for investigations are similar, yet the actual plan of management will differ slightly. Whenever we have a local recurrence, it's important to differentiate between 2 local recurrence and a second primary, and we talked about it yesterday. You have to see, is it a local recurrence or a true or a new primary? They will have impact because a second tumor, a second primary, will have a favorable prognosis compared to a true recurrence, but also will have an increase in contralateral diseases. All have to be biopsied, and please do full-scale histology, receptors, whatever your markers are, ER, PR, HER2, if you like to do also the Ki-67, and compare it with the original pathology. Whenever we confirm it, we also talked about it yesterday, a full-scale investigations will be needed, because you're not just concerned about local recurrence. Is it also part of a more systemic recurrence? We remember that in the past we used to think, and still very logic, is local recurrence those actually circulating tumor cells in the blood, and the blood that fell into the cavity of resection settled there and caused the recurrence? So is it part of a more widespread recurrence or not? So full history and physical examination is mandatory. History of the first episode, you need to know the interval between the original treatment and the second episode here. Everything you need to know about the original disease. Full comparison between the first disease and second. We're talking about histology, and we need some blood investigation. You need to check the CBC as a standard, the kidney profile, liver function test, bone profile, please. Whether you will do also CA15 or 3 or not, it is controversial, but I do it. Full knowledge of the original management plan. What was the histology? What was the type of surgery performed for this patient? Did she receive radiation or not? Did she receive boost or not? Was the axilla irradiated or not? What was the medical management? Did the patient abide with the medical management? Radiological investigation, you need to investigate it. You have a mammography, ultrasound, MRI. Nowadays you have the contrast enhanced mammography, the PEM, whatever available you will use. Again, you need to assess the whole body. Am I going for a PET CT scan, a whole body CT scan, chest only radiology if I have no facility for a CT scan, abdominal ultrasound for the liver and the pelvis. Bone assessment is mandatory. Bone profiling in the blood is also mandatory. Now, the performance status of the patient, the comorbidities, how far are you going to take this patient into a whole new treatment plan? The social status for the patient and the family history of the patient, because if you have a strong family history, now you have a recurrence that might impact your management. The two local recurrence here. If the original surgery was conservation and the patient received radiation therapy previously, we all agreed yesterday that the standard is a mastectomy. Although in specific situation, further wide excision without mastectomy is possible. When you have a patient at the age of 70, 72, and is a very transparent see-through breast, and you have a small lesion right at the scar, and you discuss with the patient the management plan, mastectomy, they're not going to be happy with it, a lot of them. Can you do a wider excision even if she had previous radiotherapy? Well, you can indeed, on individual basis, yes, after discussion with the patient. But for teaching purpose, the standard is a mastectomy if she's had previous radiotherapy. If the original surgery was mastectomy, then try to excise the recurrent lesion followed by radiotherapy. And sometimes it's not easy if it is invading the muscle, but you still try to do it. But if it is not resectable, then you are going to go for a medical management. Try to transform it into an operable situation. If all fails and the patient is not fit for surgery, you get back to the radiation oncologist. If it is a new ipsilateral primary, then you're going to investigate it and you treat it as a new primary under medical or multidisciplinary situation. But considering again the first episode, what would happen for it? What happened for it? What treatment did she receive? The surgical management again would be the standard mastectomy plus or minus radiotherapy. Again, conservation here with a new primary, not a true recurrence. No, it is definitely a mastectomy. What when we have a systemic recurrence, of course, that's a medical issue. That's not really the main topic today I talk about, but treatment would be mainly medical. That will depend on the previous drugs used in the primary setting. Biopsy of a distant metastasis whenever accessible and feasible, please, we need it. We talked yesterday about solid lesions. Could we have percutaneous biopsy? Many approaches, yes, we need a percutaneous biopsy. Specifically, we talked about yesterday about the ovaries, and we had talk about whether a solid ovarian lesion in the possible metastatic situation, should it do biopsy, should we go for laparoscopic surgery? We had a very interesting discussion yesterday, but again, solid ovarian lesion, especially it is bilateral, especially yesterday with an invasive lobular carcinoma and solid ovarian lesion. We can still argue again, but I will still go for percutaneous, not laparoscopic. Surgery for an isolated distant lesion, when the expertise is there, we really need to call for it. Oligometastasis, we have brain surgery feasible, radiofrequency liver lesion, even liver resection could be performed, and we have the radiotherapy that can work on bone metastasis, especially the symptomatic ones. Early recognition of a cord compression is mandatory. Please, every patient who has a spinal metastasis should be warned. If you have any disturbance of maturation or increasing pain, weakness in her limbs, it's what we call in England the blue light situation. Has to be referred immediately, almost within 6-7 hours, to either radiation center or a neurosurgical center. Patient have to be informed, made aware of that. Psychological support is really mandatory. Well, it's very distressing. When a patient dies from a disease that they cannot see with their own eye, it is bad. But imagine when they can't see the external manifestation of it. It's very, very distressing. So we need a proper trained breast care nurses, palliative team, because a lot of these diseases are painful, and psychological support is mandatory. Involve educated patients and families in the decision making. Involve them in management plans. We don't have, this is how it should be done. No, there are always first plan and second plan, plan B, C, and so on. Transparency with the patients. You cannot hide facts with the patients. Unfortunately, we see it happening in our countries here. You cannot hide facts with the patient. As long as the patient is fully aware, she has to be informed of the diagnosis, not just her relatives. Factors affecting local recurrence, the margins, no ink on the resection margin for invasive cancer, 1 millimeter according to the Association of Breast Surgeons in UK, 2 millimeter for America for the DCIS. Resection techniques, nowadays we do a lot of oncoplasty, but please be aware of the contamination whenever you open at a tumor. We see a lot of people doing periareolar incision for a tumor that's about 4 or 5 centimeters away from the areola, and I would discourage that. For the radiotherapy, proper radiation techniques, doses, and boost the tumor bed should be facilitated by you, Mr. Surgeon, putting wire clips and whenever possible at the tumor bed, especially in the era of oncoplasty. We sometimes excise the tumor from the upper inner quadrant, but the incision actually is lower areolar. Timely treatment guidelines here are needed. Original disease biology, receptor status, more so on the triple negative grade 3 HER2 positive disease, more in lobular carcinoma, skin or muscle involvement could always carry a risk of higher recurrences, presence of DCIS with the invasive disease and the BRCA diseases. The nodal disease, more than 3 lymph nodes, always have a higher risk of local recurrence or systemic recurrences. How do we reduce this incidence? Proper multidisciplinary approach. We talked yesterday with Dr. Bahadir and Dr. Rasha Kamal that we surgeons have to look at the images. We're not looking at the image to make a diagnosis, but will help us a lot to site our incision and plan our excision to minimize the contamination. So again, yesterday we had a very interesting discussion. You, Mr. Surgeon, get used to looking at the X-ray yourself. You're not making diagnosis, but it will help you a lot in planning your incision. Utilization of the best available radiology tools. Do not operate without a prior histological diagnosis. Never conserve invasive lobular carcinoma without a prior MRI. Never conserve a Paget disease without a thorough search of a hidden disease. You need an MRI, as Dr. Rasha Kamal said. Margins, the bigger the better. Is it DCIS? Is it 1 millimeter margin, 2 millimeter margin? Oncoplasty, always remember, it's not a pure cosmetic surgery. It is a cancer control surgery. Intraoperative, perioperative ultrasound scan, intraoperative frozen section. Dr. Bahadir raised that question. Radiation therapy and boost to the tumor bed. Proper medical management, proper communication between the surgeon, radiologist, and pathologist. We always say, you, surgeon, as good as the pathologist and radiologist working with you. They get it wrong, you get it wrong. And the patient carries your name. And remember, guys, don't consider a positive margin as a stigma. It is not a stigma. Actually, possibly in UK, the 16% of the patient would have positive margin and they might go back to theater. It is not a stigma, unfortunately. in Bahia, it is considered a stigma. It is not a stigma, please. Don't feel bad. Go back to take the patient. Don't mutilate the patient to get a bigger margin just because you are worried they will really stigmatize you that you got a positive margin. It's not a stigma. Thank you very much.
Thank you, Dr. Ashraf. The discussion is going to be by the end of the session. And now I call again Dr. Bahadir. He's going to present a very debatable issue about the surgery to the primary site in de novo metastatic breast cancer patients.
Thank you very much again, dear Chairman, dear colleagues. Good afternoon again. So in this talk, I will talk about the role of surgery to the primary site when you have a metastatic disease. But I will mostly concentrate on the oligometastatic disease because all the studies so far show that only maybe a surgery to the primary site may have a role in those patients. So far, we have 6 randomized studies worldwide, and the first one was published back in 2015, and we now have 8 years and 6 studies. One study not published yet, and full paper only announced in ASCO 2023, which is the Japanese study. When you look all these studies, they are not the same. First, because the design of the studies are just divided into 2. The first group of studies were designed on a prospective randomized study, but first they will receive systemic treatment. At the end of, let's say, 4 to 6 months, if there is a response to the systemic treatment, then the patients were randomized into surgery versus no surgery. But in the second group, including the Turkish and the Egyptian study, which is a small study, but I also put it in here just to mention it because some meta-analysis also just included this study for the analysis, the final analysis. So here, all the patients are randomized at the upfront, either to the surgery or the systemic treatment. Again, some study included advanced disease more, and some studies advanced all the metastatic sites, but also like Turkish study, mostly the patients are only oligometastatic and bone metastasis. And when you look at it, this number is more than 70%. So, starting from the first study in India, this is a study from the Rajendra Badwe from Mumbai, reported back in 2015 with only a very short follow-up with 23 months. So they started with a systemic treatment, and if the patient had a good response, they randomized their study to the surgery or not. But at the end, they didn't find any survival advantage when they do the surgery in these patients. But when you look in detail in this trial, you can see that the patients are really poor patients. I mean, they are advanced, and 94% had an unresectable disease, although they received a systemic treatment in the beginning. But at the end, again, they just randomized these studies from the pool of patients that have advanced and unresectable breast cancer. And we don't know the resection, I mean, whether it is complete or not. They didn't give any information about that. And also, when you look at the systemic treatment that they are giving, they are substandard. For example, there are 15 to 20% of the patients are HER2 positive, but they never received an anti-HER treatment in this group. So also, when you look at it, the overall survival is very, very low, although the follow-up is very short. And also in this trial, when you go again in deep, so there's no difference in whether this is oligometastatic or more metastatic, bone-only metastasis or other metastatic sites, or whether this is hormone positive or negative. In every subgroup, although the power of the study is decreasing, they didn't find any difference. So, but also there's one difference where that they find that with the surgery, they find a longer progression-free survival, the local regional progression-free survival, and that's understandable. Coming to the second trial, which was published last year from the North American, which was waited long by Seema Khan from Chicago, and Seema just reported with a follow-up of 53 months. So they again give a systemic treatment. If the patient give a response to this treatment, they randomize their patients into surgery and no surgery, and they randomized 256 patients in here. So 3-year overall survival were similar in both groups. And the median overall survival were 55 months in the local regional treatment group and 53 months in the systemic treatment only. But again, like in the Indian study, they find a significant difference in the 3-year local recurrence progression, local regional disease progression survival. So it is understandable. You're removing the surgery, you're removing the tumor, so there's no tumor anymore. So that's what, when you don't see the tumor there, and then you have a stabilized disease there. But in time, of course, because the tumor is still there in the systemic treatment, if they don't have an effective response to the systemic treatment, the patient is living with the disease if she wouldn't have a surgery on that. So again, they find the similar findings in their subgroups, like, you know, in hormone positive subgroup and the HER2 subtypes, they found a similar overall survival. Only one difference is in the triple negative ones, the surgery, the patients who had the surgery went worse. So that was interesting here in this study. Maybe the surgery may have a detrimental effect in some subgroups. So we have to keep this in our mind. But the number of patients here is 20, very, very, you know, low. So again, in this study, half of the patients, either they are T4 on N2 and 3 disease, which is the advanced diseases, and 36% of the patients have a skin or chest wall involvement. So they included many patients, they have an advanced disease. And only 38% of those patients had a bone metastasis. So you just remember this number, because when I come to the Turkish trial, you will see that we have more than 70% of patients with a bone metastasis, because at the end, there's a difference in overall survival. Maybe it is dependent on this subgroup or this feature. And here again, 16% of the patients only have oligometastasis. So again, when they look at in detail as a subgroup, they find it as a sub-analysis, and they found no difference in overall survival in less advanced disease, oligometastatic group, and the bone-only metastatic subgroups. That it was similar with the Indian study. So again, of course, this study also has some limitations. 14% did not undergo in the surgery group, 8% had incomplete resection, 15% had surgery after 3 months, and 15% did not receive whole breast radiotherapy after breast conserving surgery, and 40% did not receive radiotherapy even after mastectomy. These are the advanced cases. Most probably they had the indication, but they didn't give it because these are the metastatic patients. And only 60, and you can see this in the systemic treatment group, 15% also received surgery. So why we are, you know, insisting on doing an margin-free, you know, surgery in these cases? Because there are some meta-analysis show that they just included many studies that impact of having an R0 resection, even in these cases with an oligometastatic or metastatic disease, they found that local regional surgical treatment that with the margin negativity had a benefit in patients with negative margins. So that is why we are asking people, if you're doing a surgery in these cases, please try to achieve a negative margin here. What about the radiotherapy? Because I showed you that in the study from the North America and from the Indian study, there were nearly 40–45% of patients did not receive radiotherapy. Again, another study from the SEER database, this is not a meta-analysis, but they found that postoperative radiotherapy provided better breast cancer specific survival and overall survival in all ages and after all surgery types, including in mastectomy patients as well. And also patients with luminal and triple negative breast cancer patients and bone-only metastases had better overall survival and breast cancer specific survival after they receive radiotherapy. So that's why we also ask people to give appropriate radiotherapy after doing a local regional treatment in these patients, not only with surgery. So role of axillary dissection was never been asked in these cases. So only the Turkish trial just included those patients did had either a sentinel node biopsy negative, no axillary dissection, or an axillary dissection in these cases. Again, another study, it's a population-based analysis from the SEER database. The Chinese did it as an axillary lymph node dissection, improved the breast cancer survival, the specific survival, and overall survival. The Japanese study, they just reported this back in 2023 in June in ASCO in Chicago, and also they found that the overall survival is similar. But the important thing here is that at the bottom line, as you can see, in the subgroup analysis, this you know, the regional surgery, local regional surgery, improved survival in patients with hormone-positive tumors, premenopausal status, and single organ metastasis, not only confined to bone, but it's the one metastatic site is just regarded as an oligometastasis. Coming to the other group of as trials, which is just they randomize studies from the front. That means that they randomize studies and they give surgery, or they do surgery, or they do not surgery and continue with the systemic treatment. This study from Mansoura University, it's back in 2016, but it is a very small sample size study with a very short follow-up, but they didn't find an overall survival difference between two groups, whether they receive a surgery or not. So coming to the Australian study, this is the positive trial. Unfortunately, they stopped this trial very early with the 38 months and similar overall survival they found it. But when you look at, again, detailed in the luminal A, they find that overall survival difference in benefit of the surgical site. They didn't report it because this is underpowered, and 20% had, again, incomplete tumor resection, and only 20% received radiotherapy to breast and chest wall. And remember the meta-analysis that I showed you. Coming to the Turkish trial for the last 5 minutes, I can tell you that the Turkish trial had the longest follow-up period with the 10 years. And Turkish trial found that the surgery is superior to the systemic treatment only, with an absolute difference of the 14%. But here, of course, you should look at the subgroups. So in the subgroups, the overall survival is confined to the ER/PR positive tumors and the solitary bone only tumor, only metastasis. So at the end, of course, it also has some limitations, because when you look, there's an imbalance between the two groups. So there were more favorable tumors in the surgery arm, and when you look at very carefully, the surgery arm had more hormone-positive tumors and less triple-negative tumors. And of course, when you look at more comparison with the American study and the Turkish study, you can see that, if I can show you, I don't know if I can show you here, you can see that, maybe here, the surgical arm, the survival are the same in the 3rd and the 5th year. That 60% of the survival in the 3rd, the overall survival in the surgical arm in the Turkish study, 68 in the North American one, and the 5 years, there's no difference. The difference is in the systemic treatment work. So Turkish trial has a lower survival than the American one. Maybe this is the reason why, because they're using a more contemporary maybe treatment in their patients that are having a more survival in their systemic group. But if you're working in a low budget country, low income country, maybe it's not possible to use those systemic treatments. Maybe surgery may have an advantage to have it here. So again, in the meta-analysis, when you look at it, including this Egyptian study as well, as you can see, only those 3 studies which randomize their patients into surgery and no surgery at the beginning, they found as a meta-analysis what the survival advantage when you do a surgery in the beginning comparison to the systemic treatment. But all of them showed that one distinct feature. Every study showed that there is a significant difference in local regional disease progression survival, because you're removing the tumor and patients having a very high quality of life. They maintain their quality of life. They're not living with their tumor in their breast. So all 6 trials show this very, very clearly. So as a conclusion, well, it's still debatable that surgery should be done in all metastatic cases. We can't say this, but we may have some notes from these 6 studies. And as a common thing, excluding the first 2 studies, all of them are showing that if you have a solitary bone metastasis, if it's an oligometastasis, if it is a luminal A tumor or luminal B tumor, there might be a advantage to do a surgery in these cases. But all cases should be handled in the multidisciplinary team meetings, and this decision should be made jointly with the medical oncologists, radiation oncologists, the surgeons, radiologists, and the pathologists. And never forget that at least you have an advantage when you do a surgery, but that should not be the only reason, that when you're removing the tumor, you've been giving advantage for the patient as by means of quality of life. Thank you very much for listening to me. If you have any questions.
Thank you, Dr. Bahadir. We will call again Dr. Yazan Masanat. He will talk about a very important topic, the proper timing of risk-reducing surgery.
So many thanks again for the introduction. So this will be more like a summary of the lovely session that we had yesterday with genetics. We had beautiful talks by Bahadir and Julia and the others. So I'll touch on a few things. So when we talk about risk-reducing surgery, the right timing for that, we need to remember that there's two different scenarios. One is a risk reduction surgery for patients that had no cancer, and one for the contralateral risk reduction surgery for patients that had cancer. And the key thing is to do the surgery before they have a second tumor or they have a tumor. When you look at the risk-reducing mastectomies for patients that never had tumors before, we need to look at three main categories: the gene mutations, the high-risk family history, and the patients that had previous chest wall radiotherapy before the age of 30. And it's not that difficult to estimate the risk, but you need a team to be able to do that. For the genetics variants, each gene and each variant of the gene will have a different risk. While for the family history patients, there are certain models, mainly are based on Western societies, but there are certain models that will give you a risk estimate, a lifetime risk estimate, like the Budishia and the Tarikuzic and the Manchester. So by definition, both NICE guidelines, the NCCN guidelines, all guidelines agree that lifetime risk of more than 30% should be considered for risk-reducing surgery if the patient wants that. And if you look at the different genes, the BRCA1 and the BRCA2 are the known ones, and the peak incidence is mainly in the 40s, 50s, with nearly 60-70% lifetime risk, and that's a key thing. Remember, it's a lifetime risk of getting cancer. The PALP-P2, we know a bit more about it now. The risk is variable, but it does vary between families. Some families, the risk is 60-70%, some families it's lower. And the TP53 for the leishmaniase at a younger age. There's lots of other new genes like the ATM and the CHEK2, but it becomes even more difficult when somebody has a significant family history with a calculated risk of more than 30%, but you cannot identify a gene. Because those patients most likely have a gene that we don't know of yet. And what you need to look at is the actual risk, not the lifetime risk. So if all those ladies have a BRCA gene, then their lifetime risk is the same. It's about, let's say, 70%, but their actual risk is not the same. The residual list is not the same, because if somebody is still in her 20s or her 30s, her lifetime risk is still 60-70%. But if they reach the age of 60, then their lifetime risk might be less than 20%. And if your residual risk is less than 20%, you should think again about doing an operation like that. This is an important concept that not everybody is grasping. And if you look at the risk of breast or ovarian cancers in the BRCA1 and BRCA2 mutation, you can see the takeoff for the BRCA1 is earlier than BRCA2 in the late 20s, and they plateau in the 60s, 70s. And why is this important? Because if you look at patients that are identified to be risk carriers of BRCA1, BRCA2, beyond the age of 60 and they did not have cancer, their residual risk is 20% for BRCA1 and less than 20% BRCA2. So if somebody is found out to be BRCA positive after the age of 60, it might not be justifiable to look at risk-reducing surgery. And if the patient is eligible, they are offered the risk-reducing surgery. It's a process. It's not just you sit with the patient, tell them we're going to do the mastectomies and have reconstruction. You need to have a geneticist, you need to have a clinical psychologist, you need to have specialist nurses, you need to have the breast surgeons and the plastic surgeons, depends on the type of reconstruction. And the uptake of that is low. In the UK, the Manchester group, which is the biggest group that has done lots of work 10, 15 years ago, the uptake was between 30 and 40%. If you look at France, the uptake was only 7% to have risk-reducing surgery. Of course, there's other strategies like monitoring, like chemoprevention, and surgery is not a small thing. So let's leave the risk reducing scenario and let's talk a bit about the cancer patients, the contralateral mastectomies. I think there's lots of papers that I quote that Bahadir has quoted yesterday. We might reach a similar conclusion, but also at the same time a bit of difference in the conclusion. The key thing is to treat the cancer. So if somebody has a grade 3 triple negative node positive, I will worry about the cancer. I will not talk about the contralateral risk reducing surgery. I want to treat the cancer, and if they're okay after 2 or 3 years' time, then we talk about risk reducing surgery. So you treat the cancer and then look at the gene, and you need to look at the risk from both. If somebody is diagnosed with a small grade 1 or a small lobular, and you think the risk from the cancer is not very high, then risk reducing surgery at the same time will come into the equation. Good prognosis tumors, I don't have any issues offering bilateral mastectomies. Tumors that have heavily node positive disease that are likely to have cause problems and recur, I wouldn't do that. We will just treat them and revisit the gene in 2 or 3 years' time. And there's lots of guidelines from the NCCN guidelines and NICE guidelines who to test. We usually test patients that are diagnosed under the age of 40. Bilateral cancers, average age of less than 60. Every single triple negative is tested now. Breast and ovarian cancer at any age, male breast cancer, and patients that have family history with a Manchester score of more than 15. And some people are talking about blanket testing of all newly diagnosed patients. And many people feel that this will cause more problems because the patient is under lots of stress. They've been just diagnosed. You're adding more stress on them knowing that result. But if you look at the surgical decisions for ladies that had BRCA gene, so we're not talking about what I would do, we're talking about what patients did in the past. So this is from the Manchester group. 158 patients were diagnosed, and 65% of patients that were diagnosed and they knew that were gene carriers, they opted to have bilateral mastectomies and reconstruction. And 60% of high-risk patients that did not have gene. But the patients that were diagnosed elsewhere, they did not have a genetic testing, and then they're referred and found to be gene positive. After finishing their treatments, only 10% opted to have the mastectomies and reconstruction. That's from the UK, but a similar one comes also from the States. So patients that were known to have gene positive, 3/4 opted to have bilateral mastectomies. The ones that did not know that they had the abnormal gene, only 14% had bilateral mastectomies. And a similar paper by Shiva has been quoted quite a lot yesterday, that the ones that did not know that they were gene positive, nearly 50% had breast conserving surgery, which is not unsafe. It's very safe in those patients according to the POSH trial also, while very small percentage in an American setting had bilateral mastectomies, while the ones that had gene abnormal mutations, nearly 80% had bilateral mastectomies. The question, is there any benefits? And we go back to the Shiba paper, and if you look at that, you can start seeing that there's risk of getting contralateral disease mainly after 5 years, but more significantly after 10 years. And why is that important? Because if you have somebody that has high risk tumor, why should you do the other side if there's a good chance that they might not survive the 5 or the 10 years? So the ones that have poor prognosis, I wouldn't do anything for them. The ones that have good prognosis, then we can talk about that. A similar paper from Manchester, from Evans, mainly looking at 600 patients, 100 with 100 match control ones with a nearly 10-year follow-up. Here they saw that there is benefit from contralateral risk reducing surgery, even overall survival, independent of a BSO grade or stage, but there will always be a bit of bias in the selection. And this is another paper that came, I think, from Ireland, looking at the contralateral mastectomy, also quoted, I think, yesterday, and they're looking from the year 10 beyond. And of course, if you have a breast, you're more likely to have breast cancer. If you don't have breast, you don't have breast cancer. So the possibility of survival 10 years beyond the years of diagnosis, you can still see that their survival is splitting. But still remember, the lower one is still in the 80%, so it's quite high survival anyway. So for me, you remember that the short-term prognosis, the problem that you're trying to avoid is mainly affected by the index cancer. Remember that many of the BRCA ones have triple negatives. Remember that one of those ladies will need to have their chemotherapy. Then they need to have their other treatments and adjuvant treatments. And if you're going to do bilateral mastectomies and reconstruction for them, then you might be delaying their other treatments. So if it's a big tumor, poor prognosis tumor, you need to treat that tumor. And it's also a big decision for the patients. And if you look at the data, the ladies that did not know that they had abnormal genes did not even think about having bilateral mastectomies. And sometimes we're pushing them to have the bilateral mastectomies. That will have lots of other issues on body image. That might affect also other treatments. Sometimes we do genetic testing that might affect what we give oncologically. But with the larger tumors, sometimes all what we need to do is treat the cancer first and then think about the gene later. For the smaller good prognosis tumors, yes, you can consider contralateral risk-reducing mastectomy. If you look at the Cochrane library, there is one Cochrane review looking at all of that. They had 61 observational studies with 15,000 women. And the conclusion is that, yes, there is reduction of incidence in breast cancer specific mortality, particularly for the BRCA1 and BRCA2 mutations, mainly because you're doing the mastectomies, they're less likely to have any cancers. But the study consistently reported reduction in incidence of mortality for the contralateral risk-reducing mastectomy, but they were inconsistent about improvement in disease-free survival. And let's remember, it's not only about survival. It's a traumatic journey for the patient to go through chemotherapy again, to go through counseling again, to go through other treatments again, to go through the side effects of treatment. So yes, the survival might be better, but the quality of life and the things that they have to go through might be completely different. We are de-escalating many patients' surgical treatments. We're heading now towards less surgery for the triple negatives and the HER2 positives. But for the ladies that do not have any cancer, the gene mutations, we're escalating their surgical treatments and doing risk-reduced surgery when there is no cancer. But that's reality, that's how things are happening. So the contralateral mastectomy really depends on the biology of the disease and prognosis. And the risk-reducing surgery, the best timing is multifactorial, depends on the gene, family, and the patient choice, and you need to do it before they get the cancer. Many thanks for listening to the talk.
Thank you, Dr. Yazan. Now the next speaker, Professor Dr. Omar Farouk, Professor of Surgical Oncology, Mansoura Oncology Center, and his talk at granulomatous mastitis, the dilemma.
Thank you, dear Chairman. Thank you, dear professors and colleagues for attendance. Big dilemma, the granulomatous lobular mastitis. However, we would like to simplify this disease. The first researcher who described this disease in 1972, the Israeli Kessler and Walash from Tel Aviv University in occupied Palestine. But Going and colleagues in 1987 recommended the term of granulomatous lobular mastitis to be used as being more specific. In 2012, Briera and colleagues recommended the term of idiopathic granulomatous lobular mastitis to be used, which is more descriptive. We have chaired in an international multidisciplinary consensus 2 years ago, and we recommend the granulomatous lobular mastitis as widely accepted definition. It is a benign chronic inflammatory condition of the breast characterized by non-caseating granulomas with microabscess formation confined to the breast lobules, mostly seen in females of childbearing age within 7 years of the last pregnancy, weaning, and associated breastfeeding. Clinically, pain, breast mass or masses, breast abscess-like inflammatory changes, subcutaneous collection, sinus formation, usually the first manifestation. Also, skin changes, erythema, edema, ulceration, and sinuses were reported in 66% of patients. Axillary lymphadenopathy present in about 15 to 30% of patients. The diagnosis based on ultrasound, which revealed heterogeneous irregular hypoechoic mass lesions in more than 80% of cases. Tubular hypoechoic configuration areas with finger-like structure connecting to the mass in about 50% of patients. In absence of mass lesion, the ultrasound evidence of area of mixed echo pattern with parenchymal deformity, multiple collection, pockets, tracts, focal mastitis, and the interstitial edema may indicate the presence of the disease. So both clinical and radiologic findings are not sufficient for diagnosis of the disease because not disease specific. So the role of this investigation is to exclude possibility of malignancy rather than confirming the diagnosis of the disease. And core needle biopsy play a very important role in diagnosis. The major histopathologic changes is lopulocentric non-caseating inflammatory granulomas, which differentiate it from TB mastitis associated with microabscess formation. The etiology and pathogenesis of this disease, it is an inflammatory reaction and localized granulomas response triggered by presence of extravasated secretion and milk proteins within the interstitial breast tissues resulted from rupture of the breast lobules as a consequence of microtrauma from breastfeeding or milk stasis due to obstruction caused by maybe local irritants or undetected infective microorganisms. But the milk stasis play a key role within the breast developing into hypertrophic and fragile state consequent to pregnancy, lactation, and hyperprolactinemia. Some authors claimed autoimmunity, but in most cases, a comorbid autoimmunity disorders represent only minor fraction, and in most cases, serologic markers usually negative. Taylor and colleagues in 2003 from New Zealand, the first who detected Corynebacterium in pathogenesis of this disease, and most of these Corynebacterium were Corynebacterium croppenstedtii. We have noted in literature since 2017 a paradigm shift towards the infective theory, many articles and reports coming from many countries, from Australia, from Europe, from USA, and from China describe the role of Corynebacterium species in the pathogenesis of this disease, and most of these organisms occurring in the gap between the Corynebacterium and the Mycobacterium TB. Another report from Sweden claimed the rickettsia and recommend tetracycline treatment. Recently, 2 years ago, another article from China proved mixed infection and multiple microorganisms involved in the pathogenesis and recommend lipophilic antibiotics like rifampicin and prolactin inhibitors in treatment. Our colleagues in this international multidisciplinary consensus asked why granulomatous lobular mastitis usually occur in the Mediterranean region and developing Asian countries, and our answer is that the prevalence may be a reflection of underdiagnosis of the TB mastitis. Sometimes routine histology studies are not sufficient to rule out the diagnosis of the TB mastitis. Also, presence of atypical Mycobacterium may also involve it in pathogenesis of the disease, which are usually difficult to isolate under routine culture conditions. Regarding the lactation habits, we have noted that the poor habits of lactation and weaning in Asian and our locality in Mediterranean may lead to milk stasis or galactostasis. For example, patients depend on lactation only from one breast and neglect the other breast, which is more risky to develop the disease. Also, many patients neglect the routine breast massage and the complete evacuation of both breasts after each time of lactation. Also neglect this routine breast massage, complete evacuation of both breasts, and bromocriptine therapy during the first weeks of weaning. Another cause for the disease is long-term use of antipsychotics that may increase the levels of prolactin, and here bromocriptine should be indicated. Regarding the treatment, till now there is no consensus for optimal standard treatment. Also, there is no randomized control trials demonstrating the efficacy of each modality. We have many modalities. The first one is observation, because spontaneous resolution of the disease occurs in 50% without any treatment in 1 year. It is suitable for small unifocal lesion with mild symptoms and the only treatment during pregnancy. This article investigated the comparing between the watch and wait strategy or observation and corticosteroid, and similar results were found. However, the recurrence rate in observation is about 11%. The second choice is surgery, wide local surgical excision, often done to localize uncomplicated discrete mass. Clear margin is mandatory to avoid unnecessary mastectomy. However, the recurrence rate ranging from 35 to 50%, also repeated surgical intervention and poor cosmetic results and even massive contour deformities of the breast and repeated abscess development may occur, as you say in these photos from Mansoura. Some authors recommend skin-sparing mastectomy and immediate breast reconstruction with autologous flaps, suitable alternative surgical choice, especially for diffuse and multifocal disease. However, it may be ineffective because abscess may recur from residual breast tissue. The third option is corticosteroid, which is widely used in literature. The first one who used this in large dose, De Hertog from Belgium in 1980. Most regime 30 milligram per day dose for 3 to 6 months, which is optimal. However, the systemic corticosteroid is not the ideal treatment because it has many side effects, and sometimes the patients stop the drug and not complete the course due to some side effects and complication. Also, recurrent rate reported as 15 to 50%. Indeed, failure to respond to systemic corticosteroid suggests the infectious etiology and culture of Corynebacterium should be considered. In practice, may be administered after surgery in complicated resistant cases or when surgical margins are dirty. It could also be used before surgery in large unresectable lesions, in more diffuse lesions to be downstaged and become more localized, amenable for successful surgical excision. This recent meta-analysis, including 12 studies and more than 500 patients, recommend that the only use of steroid may be less effective than the combination of steroids and surgery. Steroids should be combined with other modalities. But in our practice in Mansoura University, we recommend the systemic corticosteroids only in patients with extra mammary manifestations like inflammatory arthritis, arthralgia, erythema nodosum of the legs, only for short periods, 1 or just 2 weeks, to avoid side effects. The presence of erythema nodosum in the legs indicates that the condition becomes more severe and the course of the disease becomes longer. It is more likely to be found when the breast lesions range more than 2 quadrants. The fourth drug is methotrexate. It is immune suppressant. It is indicated in resistant cases to the maximal dose of corticosteroid or failure to respond to the second cycle of corticosteroid. Bromocriptine also could be used. The rationale that hyperprolactinemia may have an etiologic role in development of the disease by overstimulation of the breast parenchymal tissue. Elevated prolactin levels have been identified in patients with recurrent granulomatous mastitis, although this association not have been consistently observed. In most cases, the mechanism is prolactin receptor hypersensitivity rather than real hyperprolactinemia. The first one used this drug is Agha Janzada from Iran in his largest series. He used bromocriptine with steroids in recurrent cases with good response, more than 30% of patients. What about the antibiotic? There is a limited rule for antibiotic. It should be guided by results of microbiologic culture and secondary infection. However, recent article from USA recommend that we should investigate the lipophilic antibiotic in management of granulomatous mastitis. Lastly, rifampicin. We have investigated this drug for the first time for the treatment of this disease 10 years ago, and we have published our results in World Journal of Surgery since 2017. The rationale based on that the data supporting the effective theory, we hypothesize that mixed infective microorganisms may be involved in the pathogenesis of the disease, most of them atypical microorganisms, difficult to be isolated in ordinary cultures. We further hypothesize that most of them may respond completely to rifampicin by a mechanism similar to that of Mycobacterium TB. Our prospective study was including 13 patients proving the efficacy of rifampicin therapy regimen of 300 milligrams twice daily for a period of 6 to 9 months without any recurrent episodes, so it could be used as a solo medical therapy alternative for both surgery and corticosteroids. We have many cases in this year. I think the number reaching that more than 150 patients treated totally with rifampicin. These photos showing the progress of the disease with rifampicin therapy. Many cases treated with this solo medical therapy, and here this photo showing the ultrasound criteria of progress of the disease during the treatment reaching complete resolution. And these figures also show the progress of clinical and ultrasound findings with rifampicin treatment. The last question, could we put an algorithm for treatment of this disease? Yes, in literature, we can classify the disease into 3 categories according to the severity of the disease. In localized small lesion, observation only. In moderate lesion and large diffuse complicated lesion, we can choose between steroids and surgical excision according to patient preference, and we can switch from one modality to the other or combining both modalities according to the response. But in our practice in Mansoura University, we didn't use the corticosteroid or surgery. 10 years ago, we have depended on the rifampicin therapy as the solo therapy, and we can optimize this treatment by bromocriptine for 3 months and ultrasound guided aspiration, especially a large collection more than 4 centimeters. In conclusion, granulomatous disease is chronic inflammatory breast characterized by non-caseating granulomas. Milk stasis play a key role. We have many choices, and the self-limiting nature emphasizes the need to tailor the treatment according to the disease severity. In our practice in Mansoura University, rifampicin is effective with very low recurrent rate and could be alternative for both surgery and systemic corticosteroids. Finally, granulomatous mastitis is not a surgical disease and it could be treated medically without any surgical interference at all. Thank you.
Thank you, Professor Omar, for the update in such important issue. And finally, we have the Dr. Ahmed Rafat from Ansel for the company presentation. And then we do the discussion, inshallah.
Thank you, Chairperson. Thank you for attendance. We will not take more than 7 minutes. We will talk about how to choose the glove when we are dealing with the chemotherapy drugs. So first thing that, as you all know, one carcinogenic molecule can cause cancer, and we have many side effects that we are dealing with any carcinogenic molecule or any chemotherapy drug, that like headaches, irritation of skin, hair loss, and maybe more severe than genetic damage, infertility, and miscarriages. So we need to know which glove we use when we are dealing with the chemotherapy to avoid all of these side effects. So as all the standards that mentioned for the skin permeation, it's regarding the permeation of the chemotherapy drug when she pass our gloves and go in direct contact with the skin. So European standard make a concentration for permeation rate 1 microgram. She tests the 1 microgram when she passes to the skin, so that it measure only 1 microgram only for passes the glove material, and that we have two American standards. One measure 0.1 microgram when passes through the glove material, and the last one is 0.01 microgram. For all these standards, it's static standards, not a dynamic standards. So all the standards measures the permeation according to static one. So Ansel need to make an actual condition for wearing the glove. When we wear the glove, we have a dynamic reaction. So we make a CPP, dynamic permeation testing. While we are using the glove, we have body temperature maybe from 37 to 42 when we make a high peak operation and the organs become more high temperature. And we have also the flexibility of the glove. When we stretch the gloves, the material of the glove becomes thinner. So we want to know this, the permeation of the chemotherapy drug during this phase will allow to permeate how long for the chemical substance or the chemotherapy we are using. So what is the test done? The test done is, as you all know, the guidelines, we are wearing any of the surgical gloves, we must wearing for only 30 minutes. After 30 minutes, we need to change the glove when you are dealing with the chemotherapy drug. So the study make at 30 minutes for the ACPP, the Ansel invented. Regarding the standards, make at 240 minutes, which we don't use the glove for 240 minutes. And the test type is dynamic, not static. The standards make all the tests in the static, and Ansel made the test dynamic to know when we stretch the glove, the material passes through the gloves or no. And the test location in the palm and the cuff. In the ACPP, we made the test on the fingers because it's only one direct contact, mainly with the organs, or direct contact with the chemotherapy drugs. The permeation rate we measure in the standards is 1, and as I said, and 0.01. But Ansel ACPP, we measure 0.0001 according to the highest efficiency of any device, like the nanotechnologies Dr. Ahmed Zuhail invented. It's measure 0.001 microgram for the permeation rate that can pass through the gloves. And the test temperature will be about from 37 to 43. And for the number of chemical drugs we are using, we use about 27 drugs. Instead of standards, use only 9 gloves or 2 gloves that we are using in this standard. So the ACCP is a dynamic, and the test is going on the actual using of the gloves when we are dealing with chemotherapy, when we are dealing with any patient in the surgery for any operation, and if they take new adjuvant in this operation with mixture of the blood with the chemotherapy. So we need to healthcare provider always will be safe when they use Ansel gloves. So for Ansel gloves, only Ansel gloves in the market that has the ACPP and has a permeation or guidelines to work with the chemotherapy drugs. No other gloves in the market has any the ACPP because it's invented only for Ansel. And this is the journals that the ACPP authors published this study. Its first journal is the Journal of Health System Pharmacy, and second one is the Journal of Oncology Pharmacy. And this advantage that allow us to choose which gloves we are using when we are dealing with chemotherapy. So we can see this video. It confirms that the choosing of the glove when you use direct contact with the chemotherapy drug. Ansel surgical gloves is #1 for choice for all over the world. It's global market leader inside the OR. It's the biggest company that sell sell surgical gloves inside the OR. The one we have here in Egypt is the Medigrip latex standard. The Medigrip latex standard, this is the table for the chemotherapy drugs that have a permeation rate according to the time and according to the concentrations that can break through time through the glove. And it's antiviral glove and antibacterial glove and be safe for your hands and has low allergy regarding any other latex surgical gloves. And all the gloves here is available at our official distributor here in Egypt is BM Egypt. And we have also examination gloves and nitrile gloves according to the needs of every one of you. So thank you. Thank you for attendance.
We can open the discussion for 10 minutes. So we can start with if any question for Professor Bahadir in both of his lectures.
مايك يا جماعة المفروض.
I think I will be more interested in the second lecture, which is surgical management of metastatic breast cancer.
Just we are talking now about the first presentation. Do you have questions about it?
لا.
Okay.
هو واقف هيقول
لا, many more questions about the first presentation first to finish it. معلش I just want to ask him. Okay. But the first lecture first. There's another question though.
Thank you. I am Maawi Dabora from Sudan, plastic and breast surgeon. Thanks for Bahia and thanks for the fruitful talks. My question is just when assessing the safe margin, generally, to limit of my knowledge that the pathologist take just samples from the surrounding. He's not going to assess the whole, the surface. And I know that there are two types of border of the tumor, pushing border and infiltrative border. Just I am asking me and all of us, as a surgeon, how can we be so confident of the result of this pathology report? Thank you.
Thank you very much. This is a very good question. No one can be certain about this. I mean, no pathologist in the world can see all the margins and say you that it's a safe margin. The only thing here is that you have to, consult your pathologist during the operation. If you think that, of course, you're not cutting it because you're sending the whole specimen to your pathologist. That's why I always recommend you as a surgeon, go to your pathologist if it is near to you. And when she or he cuts the specimen, then you look which parts of the cavity is more near, not the cavity of course, the specimen is near to the surgical margin. Then you may ask only that part during the frozen section, of course, not for the permanent. Then you may ask only your pathologist to look at that part, taking a piece of, a tissue there. Because before that, before they cut it, they paint the whole surface of the specimen. Then when they cut and look at the specimen, they can see, when they cut a piece of there, they can measure under the microscope the tumor, the distance between the tumor and the marked, inked margin. So that would be only thing that you can rely on. But for the permanent one, of course, the pathologist may take some samples from each of the bone, anterior, posterior, lateral, and medial. But again, the only indication here is if macroscopically the tumor is far away from some side of the tumor, you don't need to take a sample from there. So the answer to your question, we can't be sure for 100%. What we should do is just, if you're in a question, when you're dealing with the specimen, you can only take the pieces from the part which is nearest to the tumor.
Another
Please,
question?
can I add something to your to your answer? We can tell the patient that we are going to make paraffin section after this, so that the frozen could be not accurate, and we have to wait for the paraffin section. If there is a difference in both, or the paraffin proves that there is one margin involved, we can reshave it again in another session.
That's one of the ways that you may be sure about it. If the pathologist says that it is near to this, let's say, anterior margin, you can take a piece from there and send it to the pathologist, not for frozen, just to be sure about it, like a cavity shaving. That's one of the ways that you may make yourself sure about that.
Dr. Ashraf?
Most of the time when you talk with the pathologist, they are not comfortable picking up DCIS at the margin during frozen. Do you find it an issue? Picking up DCIS at the margin during frozen?
That's also a very good question. I mean, they're really comfortable with the invasive cancer, but the DCIS, the thing here is what we do, especially if we're not very sure about this, we also do touch print. Because touch print can pick some tumor cells irrespective from the invasive or the DCIS. If two things, the frozen plus the touch print is negative, then we say it is negative. But again, from the surgical side, if you're not be sure about this, again, another way is to take a cavity shaving on that side to be sure about it, because otherwise you can't be sure, and you have to rely on for the permanent report, and it might come back as a 1 millimeter margin to the closest word.
And a lot of the time I say to my younger colleagues when they assist me, always use your touch and the color of the tissue around you, around your tumor.
Any more questions?
But I really recommend everyone, if it is feasible, please go to the pathology lab and cut together with your pathologist. Because otherwise the pathologist would not understand which is near, which is far away, but you may say that this is the tumor, and jointly you can decide on where to cut, extra tissue to assess intraoperatively. Yeah.
Dr. Bahadir, I ask about shaving of the cavity, or cavity shaving. It is extension of the wide local excision. Like if I do wide local excision and I excise the tumor with a safety margin, and then I think about your idea for shaving, so why I don't do from the start? You get the point?
Yeah. I'm not doing cavity shaving, by the way.
Okay.
It depends on your experience. Look back to your experience. How many times you do a reoperation? How many times you do a reoperation after breast conserving surgery? In your experience, let me say it.
Like 10%. 10% of cases in the final pathology.
10% of the time you go back and you take your patient back to your operating room.
And I explain to the patient before the surgery.
So why I'm asking this, because cavity shaving is dropping from 45%, 30% to 10%. So if you're already having a 10% of a reoperation rate, that's good. I mean, you don't need to do a cavity shaving in your patients. But if you're a surgeon, I mean, at the end of the whole breast conserving surgery, I worked in those centers in other countries. I know that 30% of the time it comes a positive margin, and you take your patient back to the operating room next week. So here they need cavity shaving, or they need a frozen section. But if you're doing some kind of a surgery with a frozen section and it is less than 10%, you don't need to do a cavity shaving.
Okay, thank you.
Yeah, the last question, please. It's about the same presentation?
Yeah, about the
Yes.
same presentation. Thank you, sir, for your great presentation. But I have a question. What's your own practice? What's your own practice? Like if we have two patients here, one is upfront surgery and you need to do a wide local excision and a central lymph node. And the other case, is post-neoadjuvant with good response. Do you do frozen in any of the two cases, and do you do frozen for the center or not?
Let me give you a brief explanation about this. If it's an upfront surgery, we do a staging in the beginning, just before the surgery, for the axilla with ultrasound. Sometimes we use it PET CT, not in every case. If it is node negative, in the upfront case. If it is a luminal A patient, if it's a small tumor, we depend on this. If you remove one lymph node in the sentinel node, we don't send it to the frozen section. We wait for the permanent one, because if it turns out to be one positive, we will not do anything, even in the mastectomy patients. But if I retrieve 3 nodes in these cases, because in fact, if 3 of them are positive, you have to do an axillary dissection. Again, I depend on my radiology and the patient's characteristics. If it is really favorable, I again don't send my lymph nodes to the frozen section, because 99% of the time, maximum 1 node would be positive and the rest of 2 are negative. So again, you don't do anything. But if you're in doubt, like you're in the operating room, you can send it for frozen, because if 3 out of 3 turn out to be positive, you need to do an axillary dissection. Coming to the setting after the neoadjuvant chemotherapy, if it is 1 or 3, we send it everything to the pathology and wait for the result. If it is positive, even micrometastasis, we do axillary dissection. I hate axillary dissection, by the way. I hope that in sooner we will not do axillary dissection in those patients as well. But one instance, it is negative, you stop doing axillary, and patient went back to the ward. After 1 week, the pathologist said that it is positive. This is the case. So here, I do not take my patient back to the operating room. We send it to the radiation oncology. And so far, for I think 6 years, we didn't see any local, just isolated axillary recurrence in these patients.
Okay, and for the tumor, not for the lymph node? And for the tumor bed, you send
yes.
that.
What I do, macroscopically, it is far away from the margin. I never ask frozen section.
Okay. In both scenarios, even after neoadjuvant.
Yeah, after neoadjuvant as well. Yeah.
Okay, thank you.
Okay, about while you're standing, the second presentation, Dr. Hamdi has got a question about the surgery of the primary site in de novo metastatic breast cancer patients.
Yeah, that's a very interesting topic and very burning as well. You mentioned that the overall survival is not different, and I assume that's because of the short experience and the short follow-up in such cases. In our institute in Egypt, we are running a study on oligometastatic extracranial, less than 5. It doesn't matter if it is bone or visceral metastasis, but less than 5 extracranial. We do a PET CT, the beginning of the primary therapy, primary systemic therapy, and then we do a PET CT after the patient has finished the primary systemic therapy with complete response, and then we address the issue of the breast itself. We're still having a long time to assess if this will be feasible and will be having survival benefit or not. That's what we do in oligometastatic extracranial breast cancer. I don't know if that's such a certification as you do, because you didn't mention if it is the same or not.
There are 2 groups of studies. 3 of them did a randomization after primary systemic treatment. If they have a good response, they randomize it. And they didn't find overall survival difference between 2 groups. Only those who randomized their studies in the beginning to surgery without testing the systemic treatment in the beginning, and the other group only received systemic treatment. I mean, this group, surgery plus systemic treatment, this is only systemic treatment. From all these 3 studies, again, only the Turkish study showed that after 10 years of follow-up, just a 14% of an absolute difference in overall survival, but not in the whole group, because the Turkish study included more oligometastatic disease, more luminal A and B patients, and also bone-only metastasis. So from all these studies, what I can tell you that if you have, of course, one question should be like this: I gave 6 months of a primary systemic treatment and the metastasis is gone. So what will we do? Because all we discuss now is the metastasis is still there. Should we do a surgery to the primary? But your question is a little bit different. You know, there's no study showing us that there would be an overall survival difference in these patients when they have a surgery after breast, when everything in
Has
the,
gone.
in the-
Yeah.
is vanished, you
Yeah.
know, by or complete response. So what we do as a practice, not because of evidence, we do surgery to these patients as well, because there's a good response, like complete response in the breast. So even in these patients, if there is a remaining tumor in the breast, you may remove it.
Thank you.
You're welcome.
One question for Professor Yazan, please, because we are out of time.
Now, you also
For this issue, Dr. Ashraf. Dr. Ashraf, we don't have time now. We only have one question for Dr. Please. Can we?
We'll talk about it in private.
Okay.
We'll talk in private.
Okay.
Dr. Yazan? Any questions about the presentation? Well, okay. Okay.
Regarding the B3 lesions, because the time is very short, I know that Yazan would just mention that as well. When you're dealing with a B3 lesion, it's not just a B3 lesion. For example, if your patient, for the follow-up, if your patient the mother has a breast cancer and the sister has a breast cancer, would you do a follow-up in these patients? So what about giving a chemoprevention in these? Would you use a tamoxifen or just leave it to the screening, like, long 5 years of follow-up? So this question should go to Yazan, because there's two types of patients. One patient, 55 years old, no family history, and you have an ADH, and you make a vacuum biopsy. Let's say it's just gone away, okay? How would you follow this patient? Or would you do a resection? Another patient with the mother and the sister breast cancer, 42 years old, let's say, okay? And maybe gene testing would be required, and the patient should have a resection plus any kind of chemoprevention.
So for ADH, it's confirmed on biopsy, Bahadir. What we do is we do large volume excision of the radiological abnormality. If the large volume excision, there is no residual abnormality radiologically, and we only see ADH, then our practice is to put them in a high-risk surveillance. The protocol for high-risk surveillance is yearly mammograms, which I don't agree with. I put them on 10 years mammogram rather than 5. But chemoprevention, I'm not sure that we don't do that at all in the UK for ADH and high-risk lesions. They consider them only for the family history patients and for the gene carriers. But if you look at the gene carriers, I'm also a bit dubious about tamoxifen, because overall survival was not better for the gene carriers, because they did not get breast cancer. It decreased the incidence of breast cancer, but most of them had problems with the DVTs, PEs, and uterine cancers. So I'm always a bit reluctant from the chemoprevention, but we still discuss with patients. There might be some other options. People are looking at other types of chemoprevention. People looked also at AIs. People are looked at mastectomies. People are looked at doing just only regular routine MRI scans. There's always ways of looking at stuff, but the only thing that really decreases the chance of breast cancer is the mastectomies and the reconstructions.
Okay. Thank you. We have to end the session.